it's a disease that was described a long time ago, and it got named after Dr. Hodgkin, but the footnote is most of these people really didn't have Hodgkin's disease or lymphoma at all, but he still got famous because a lot of them had infections that were not lymphoma. So, he was just a medical student when he described this, and that was the title of the article, Morbid Appearance of the Absorbent Glands and Spleen, because they were all enlarged. And then the specific changes in the lymph nodes were described by Doctors Reed and Sternberg, and they still carry their name as the Reed-Sternberg cells as kind of diagnostic of Hodgkin's disease, but there are some instances where you get them that they don't have Hodgkin's disease, but it's still Reed-Sternberg. So this slide demonstrates the relative frequency of the different lymphomas. You can see that Hodgkin's disease is the least common of them. And the NHL, non-Hodgkin's lymphoma, there are there are really two that are the most common. That's a diffuse large B cell, and there we go with another B cell. Follicular lymphoma, which is also a B cell. And then there's a whole bunch of other ones. See, I'm going to show you. I'll show you how many other ones there are here. So, Hodgkin's disease is not very common. Like I said, it's less than 1% of all malignancies in the United States. Only 3 cases per 100,000. Again, figure out how many there would be in Oklahoma. Not that many. There are 7,500 in the United States. And for some reason, it's less common in African Americans than non-African Americans. And there is some familial predisposition, but that may be environmental too. It has an interesting occurrence. It is a bimodal distribution of its occurrence, and that it happens in young kids, young adults, and then in the elderly. So little kids don't get it very often. Middle-aged people don't get it often. You get this bimodal distribution. It may be related to EBV infection. But obviously everybody that gets EBV, Epstein-Barr virus, does not get Hodgkin's disease. But Epstein-Barr virus is especially mischievous in that it can do all kinds of things to the immune system. And it probably has some relation to Hodgkin's disease. There's now a treatment available for Hodgkin's disease. It depends upon the presence of Epstein-Barr virus antigen within the cell. But it doesn't work on everybody because not everybody has that antigen. This cell that you see up there, that is a Reed-Sternberg cell. I've heard that described as, it looks like an owl eyes. It's probably not, let's see what it say here, that most of the cells you see here aren't malignant. In fact, there's a big debate of really what is a malignant cell within all of these. So it started again in the germinal center as a B cell. The Reed-Sternberg cell, there's some that look sort of like this, but not quite, so they're just called variants. But if you're reading a path report and they say it's got Reed-Sternberg cells, you got to perk up and think that's what they're talking about. There are 4 different classifications. They have some little difference in prognosis, but not that much. This nodular lymphocyte predominant Hodgkin's disease is a different actor, and it may not even be Hodgkin's disease. There's controversy about that. But the first 4 that say lymphocyte depleted or not depleted, lymphocyte rich, mixed cellularity, and nodular sclerosis are all well accepted subclassifications. So the lymphatic system, which you studied, is really everywhere. So within the lymphatic system, you have bone marrow, thymus, lymph nodes, spleen, tonsils, adenoids, digestive respiratory tract, and just the thoracic duct. So you have lymph tissue all over, and any of that can be involved with any of the lymphomas. So we'll talk about staging. This staging is called the Ann Arbor system, like in Michigan, and So stage one is somebody has one lymph node, just one side. It doesn't matter if it's above the diaphragm or below the diaphragm. The diaphragm is used as the landmark for this staging, okay? So it's just one area. If you have two areas, but they're both on the same side of the diaphragm, that's stage two. If you move on both sides of the diaphragm, it becomes stage three. And if you start picking up a non-lymphoid organ, it becomes stage four. And a non-lymphoid organ would be, the most common would be liver involvement or bone marrow involvement. The spleen counts as a big lymph node. So if somebody has splenic enlargement, that's just another one. This Ann Arbor staging is used for Hodgkin's disease and non-Hodgkin's disease. The prognosis of Hodgkin's disease is most determined by staging, not by those four subclassifications. Non-Hodgkin's lymphoma's prognosis is determined more by the subclassification that you see on the pathology rather than the stage. Stage is important, but the cell type will predominate what's going to happen. So that's how those two contrast as far as prognosis. With Hodgkin's disease, we wouldn't want to say we wish more people had Hodgkin's disease, but it makes us look good as oncologists because usually we can cure. If up here there's a reference to B symptoms. A B symptom is like weight loss, fevers, night sweats. Pruritus can be a B symptom. So it's just kind of how sick they are. So if someone has a stage 1 or 2 Hodgkin's disease and they don't have B symptoms, they're very curable with radiation therapy alone. And the radiation therapy doesn't just go to where the lymph node is, it treats generally the region and some contiguous nodal areas. So if they had a lymph node here in the supraclavicular area, they would probably be irradiated in the mediastinal area and up the cervical chain and maybe even the submandibular chain. So they get contiguous because Hodgkin's disease spreads by contiguous lymph systems. And so that's why the staging is so predictable of the prognosis, and that it moves from area 1 to area 2 to area 3, where non-Hodgkin's lymphoma goes from area 1 to area 8. It goes, so the staging is quite a lot. Once if they have B symptoms or they have stages 3 or 4, the cornerstone of therapy is chemotherapy. And the chemotherapy is really very effective. So we'll move on to non-Hodgkin's lymphoma. This is a photograph of a guy that has lymphadenopathy. Obviously, he has axillary lymphadenopathy, and it says that he has supraclavicular, and that's what is going on right here. But looking at him, I think he probably has submandibular lymphadenopathy. You can see how it's bumped up around here, and it may even be cervical. So some people that have lymphoma really have pretty enlarged lymph nodes. I mean, they're really uncomfortable. So, again, the symptoms are similar to everything else we've talked about today. Weight loss, fever, night sweats, fatigue, the pruritus, and most people do not have generalized symptoms. They may just present with one of these, or probably the most common thing is they come in with an enlarged lymph node. Okay, so again, the cause of most of this is unknown. There are some inherited familial diseases that can cause some of it. Environmental, certain pesticides and herbicides. There have been epidemiologic studies done in Iowa and Nebraska that show that people that were involved with the application of herbicides had an increased risk of non-Hodgkin's lymphoma. And it wasn't just the guys walking around, using it in your garden. It's like the people that are industrial, crop dusters, or they use backpacks where there's a lot of blowback on them. So it's not just a one-time exposure. Radiation may cause it. A immunosuppression from HIV-related lymphomas occur. People that have had a kidney or heart transplant are immunosuppressed, so they're more likely to get a non-Hodgkin's lymphoma. Or they could, even if we did a transplant for, say, leukemia, they may get a lymphoma because they're immunosuppressed from that. So the immune system surveillance is very important in keeping us from getting these. We talked a little bit about EBV, Epstein-Barr virus. HTLV-1 is luckily not very common in the United States. It's in the Caribbean and stuff, and so, but it can cause some lymphomas. The H. pylori study is another one of those studies of folks not realizing what they found. H. pylori is found in the stomach. It is a cause of gastric ulcers. And when it was originally described, no one believed that that ulcers were an infectious disease, which they are. They all come with stress or whatever. And so the guy that described this, they lived in Australia, and obviously they didn't know what they were doing since they lived in Australia. Well, it turns out the guy's right. H. pylori does cause this, but H. pylori also causes a very indolent type of mucosal-related lymphoma, and if you treat the bacterial infection, the lymphoma will go away. It doesn't, and it occurs either in the it can be in the mucosa of the eye, is a site, and also in the gastric. Now, once it becomes an advanced lymphoma, treatment with antibiotics doesn't work, but if it's in the early stages, it does. So, again, non-Hodgkin's lymphoma is an age-related disease, even if you count all of them. They are an age-related disease. And think about that. Why is that? Well, my immune system is not as good as yours, and so as we age, our immune system kind of poops out on us, and so you're more likely to get non-Hodgkin's lymphoma. So, like I pointed out with the tissue type is very important with non-Hodgkin's lymphoma. It's going to determine the prognosis more than the stage. And it's important to get adequate tissue. There's a technique called fine needle aspiration where you just stick a needle in a lump and you aspirate and you get a few cells and you can smear it out, similar to what a pap smear is. And that doesn't give you it tells you what the cells look like, but it'll tell you about the architecture of the lymph node, which is critical because when we talk about follicular lymphoma versus diffuse large B-cell lymphoma, that language describes the appearance of the lymph node as to whether it still has follicles preserved or if it's a diffuse pattern. And you can't tell that with isolated cells. So we don't use the FNA much in lymphomas. We use excisional or incisional biopsies of lymph nodes. We also will do a bone marrow. That would help with the staging, because obviously if you have marrow involvement, that makes it a stage 4. They get a lumbar puncture if they have a non-Hodgkin's lymphoma that's sort of above the clavicles, because for some reason these tend to involve the spinal fluid. Chest x-rays, CT scans, MRIs, PET scans, they all have a role in staging. I don't want to go into the big details about that, but imaging is important. It used to be we had to do a lot of exploratory surgeries to figure out what was involved or not, and that's all gone away. All that can be done with imaging. That's too complicated this late today. What do you think? You don't really want to know that, do you? Or you don't want to know that one either, do you? I look at these, I go, now what am I going to say about that? And I forgot what I said I was going to say, and so we won't do it. All right, this makes a point. There are a hell of a lot of different types of non-Hodgkin's lymphoma, right? This, I think, I know I counted them, and I think there are 50 on here. There are 50 different subtypes of non-Hodgkin's lymphoma, and if you want to get a good nap, you go to a pathologist that starts talking about these subtypes, and your forehead will hit the desk so fast. So, but the point is there are different types, there are different prognosis, and it's the tissue type that determines the prognosis of non-Hodgkin's lymphoma. You got to know which one. Well, you can simplify this in just kind of the indolent, slow-growing, aggressive, which are bad, and the very aggressive, which are very bad. And these are described actually on the basis of their natural history, not upon their response to treatment. And so, if you look at the indolent, you'll see that our old friend chronic lymphocytic leukemia is up there with that slash from the small lymphocytic lymphoma, just like I described. It depends whether they're floating or they're sticking in the lymph nodes. These other ones are also slow-growing lymphomas. Then aggressive ones, let's see, the ones that are most, the ones we worry about the most is this diffuse large B-cell. That's probably the most common non-Hodgkin's lymphoma. These are curable. These, for all intents and purposes, probably are not, even though they're slow growing. We can treat them multiple times. Hairy cell may be the different one. That's leukemia anyway, but it may be curable now. And the very aggressive ones, even though that's by their natural history, they move fast. They're also very sensitive to chemotherapy, and most of these can be cured. These two can be cured. This one cannot. So the factors that influence the treatment. So how fast do they grow? Like this one, this Burkitt's lymphoma is the fastest growing cancer on the face of the earth. It has a doubling time in some patients of 48 hours. And it's spectacular. You treat it, the response is spectacular, and then it can now be cured because you got so many cells in cell division that they're very sensitive to chemotherapy. So, here we go. So we can measure the growth rate, and that identifies how aggressive it is. So this was that slide I showed you, 40 subtypes of lymphoma, and we talked about stage. So, we'll skip that too. So, radiation we can sometimes use in the slow-growing lymphomas. Let's say they just have one lymph node that's bothering them, and otherwise they're doing well. You might give them limited involved field radiation. Yeah, for the aggressive or highly aggressive, the chemotherapy is all going to be based, the treatment is all going to be chemotherapy, no role of radiation. And sometimes in early stage lymphomas, we can use a short course of chemotherapy and a short course of radiation, and that truncates their entire treatment regimen down to just a few weeks rather than half a year. So sometimes we'll use both. Okay, so let's see. We've already talked about Hodgkin's disease. Let's talk about follicular lymphoma and diffuse large B-cell lymphomas. Follicular lymphoma is generally slow growing. This is the one that you got to look at the whole lymph node to see what it looks like, to see if the follicles are preserved. It's usually, these patients unfortunately present usually at an advanced stage that hadn't made them very sick. Over half of them are stage 4 at the time they present. They have, I don't think you need to know that mutation, the germinal, and again, it's just a B cell. So, on the follicular lymphomas, these are the ones that sometimes we wait and watch, just like the old CLLs. They have multiple options to treat them. They can be treated. Interesting how it works is like they may go into remission that lasts 7 years. You give them chemo, and the last 7 years they do fine, and then it comes back, you treat them again. That second remission is always about half as long as the first one. So that if they have a real long remission, you treat them again and again and again until finally, your half of a half gets so short that you got to do something different. The bad thing that can happen is that they can transform into an aggressive lymphoma. They can move into diffuse large B-cell. But that happens usually with time. It's not something that happens by tomorrow. So diffuse large B-cell is the most common type of the aggressive lymphomas, and that's we spend a lot of time in the clinic caring for patients with diffuse lymphoma. They usually present and they're sick. They have night sweats. They've lost weight, they have palpable lymphadenopathy, and they may not have stage 4 disease. Usually they don't. but just the nature of the disease makes them sicker than the follicular lymphoma. Again, it's a germinal cell B cell. They all get treated up front. You don't wait and watch the diffuse large B cell. They get treated even if it's a limited stage. And this slide, it says they're curable in 40% of the time. It's probably more like 60 to 70% because of the development of medicine that's a monoclonal antibody that attacks a CD20 molecule on the cell wall. And that, the medicine's called rituximab, and it was another revolutionary drug that really has changed the treatment of lymphomas considerably. Let's see. I don't know. Category, non-Hodgkin's lymphoma. So we got the three categories, and you can see the survival of untreated patients, which goes from years to weeks with that Burkitt's lymphoma that grows so fast. They just live a few weeks untreated. Treated, they and you can see the scheme of how you treat them. The indolents are really the only one you don't treat. Multiple myeloma, okay. We're almost done. This is it. Okay, multiple myeloma. So, the multiple myeloma, the malignant cell is the plasma cell, which doesn't really have anything to do with plasma. The job of the plasma cell is to make immunoglobulins. And of all the immunoglobulins, the most common multiple myeloma is an IgG myeloma, then IgA myeloma, and there's rare IgE. I don't know if I've ever seen an IgE. There is an IgM disease, but it's not called a myeloma. It's called Waldenstrom's macroglobulinemia, which I remember that because it's the M turned upside down to make Waldenstrom's. That's another thing of science. So, but these are plasma cells. These guys right here with the eccentric nucleus off to the side and then central tower. This why this is lighter is that is the immunoglobulin that's been made by the nucleus and it hadn't quite been dumped out yet. This is a very atypical cell, which just means that this is it's not just the number of cells that are increased, but some of them are not looking healthy. So that's one that's not looking healthy. I know you haven't read many radiographs, but I bet you can tell there's something wrong. So sometimes these people present with broken bones, you know, and you can see the, well, I don't think I need to belabor this, but this whole bone is involved. See, it's white along here, and it should be about this same color, but you have these areas that are darkened. They get what's called salt and pepper changes in their cranium. These are also little holes in their skull. It isn't going into their brain, it's sitting within the skull. And let's see. And here, this is especially catastrophic in that it's in the femur. So you can imagine the guy's walking down the sidewalk and all of a sudden his leg breaks. And so that's cleverly marked so you can see it. But if actually you see that there's kind of light in here, it's kind of light in here, and so there are other myelomatous areas. Okay, who's that? Sam Walton, you're right, Sam Walton. So he died of multiple myeloma. And there's the Myeloma Institute in Arkansas that he gave a lot of money to. So he's probably the wealthiest guy to ever die of multiple myeloma. I have a lot of pictures of people that died of myeloma. You're all too young, you don't even remember them anymore. So. Okay, so myeloma fits into this large classification called plasma cell dyscrasias. And there's multiple myeloma, there's smoldering myeloma, which means they have some extra plasma cells, they may have a little bit of abnormal protein, but it hasn't reached all the criteria to be multiple myeloma. A solitary plasmacytoma is just one collection of plasma cells in the bone, or it can be in the soft tissue, like that X-ray we saw of the hip. if all they had was that little hole there, that would be an isolated plasmacytoma. And it's treated differently. It's not a systemic disease, so they just get radiation to that area. That leg probably would have got a rod too. So that's a little bit different. And then this monoclonal gammopathy of unknown significance, or MGUS. That's when someone is noted to have on serum protein electrophoresis what's called an M spike, and it's not very tall, and they don't have any other symptoms of multiple myeloma, and you don't know what's going to happen to them, so that's why it's of unknown significance. And those people can be that way for decades, or it can evolve into multiple myeloma. Amyloid is a weird disease that comes from the proteins that are made by plasma cells. And then we already talked about Waldenstrom's, which is really it's an IgM, immunoglobulin malignancy. So again, here we go, what causes multiple myeloma? You'd think we'd know more about this. We don't know what causes anything when you get right down to it. So radiation doesn't do it. It's not solvents, pesticides. There are really no epidemiologic clusters. Probably the human herpes virus 8 does not cause it. There was a lot of talk about that a few years ago, but it's kind of gone deaf here lately. African Americans tend to get myeloma twice as often as white people for reasons that are not understood. More men get it than women, and it probably has a trajectory where it all starts as that MGUS and then evolves into multiple myeloma. But not everybody with MGUS evolves. So you can't tell people that have MGUS, oh, well, you're going to get myeloma, because they may not. There's probably a stronger hereditary piece to this than has been appreciated in the past, as they do more of this gene sequencing, but it's not clear how that works. Okay. Again, this is a disease of older people. These are 60-year-olds. So you can tell before then it's pretty uncommon, and then it kind of shoots up. And all these survival curves, I don't know if you've noticed it, or the incident rate. Once you get to about 85, you don't get this. It goes back down. I don't know. Maybe these people are kind of superhuman. If it hadn't killed them by here, they just don't get it anymore. Okay, so multiple myeloma. This is important right here. That these are the things that define if somebody has multiple myeloma. It's called the CRAB criteria. Hypercalcemia, renal failure, anemia, and involvement of their bones. Because that's all spells CRAB, right? So that's how you can remember the things. If somebody has multiple myeloma, they're going to have these things. Okay. So there are two different staging. We're not going to talk about this a lot. There's the Drury-Salmon staging and the international staging. Again, it's to define the tumor mass and to determine prognosis and the intensity of treatment. So basically, these depend upon whether both of them depend. Well, let's just talk about this. So are they anemic or not? Now this is a weird way of staging stuff. Our other staging, it's kind of like you get stuff in progression to move you from 1 to 2 to 3. This one is you either are a 1 or a 3, and if you're not a 1 or a 3, you become a 2, which is kind of a funny way to do it, but that's the way it works. So they're not anemic, their calcium's normal, they just have one bone lesion. They have a low M protein, that's their serum protein electrophoresis. And their urine light chain on electrophoresis, there isn't much of that. So that's a low burden of disease, that's stage 1. Well, if they become anemic with a hemoglobin of less than 8.5, or they're hypercalcemic, or they have multiple bone lesions, well, not if, they have to have all of these things. One or more of the following. Or they have a high M protein, and Vince-Jones protein is the protein that's in their urine. That makes them a stage 3. If they don't meet the criteria to be here, or the criteria to be here, they go to here. Most of the people I see kind of fall in stage 2. somewhat simpler scheme is the international staging system, but again, and this one depends upon a beta-2 microglobulin, which is a protein that's made by myeloma, and the level of albumin in the blood. So see, it doesn't even really depend upon the size of the N protein. So this is the principle on both of them. It involves the use of whether they're anemic, whether their calcium's normal, the degree of bone marrow disease, how big their myeloma is, and whether they have beta-2 microglobulin. So these are the types of information we collect at the initial diagnosis and the stuff that we follow to see response to treatment. So, the treatment of multiple myeloma has been changed dramatically in the last 10 years. It used to be that we treated everybody with an alkylator, an oral medicine like chlorambucil or melphalan and prednisone, which is a corticosteroid. Well, now we have all these drugs, and they're about 4 of these, and about 3 of these, and 1 of these. So you combine all of these, and I have a table that is totally confusing. Just the point is how confusing it is, because nobody really knows how to treat myeloma now. We all have really firmly held prejudices. So usually what we're doing is we're given 1 of these, 1 of these, and 1 of these. We're using a proteasome inhibitor, an immunomodulating agent, and a steroid to put them in a near remission, and then we do an autologous stem cell transplant. An autologous means that they get their own stem cells back. There's no donor. Now, I think it's worth mentioning what is the leading immunomodulating agent, and that's the first-in-class drug is thalidomide. Have you studied thalidomide, heard about thalidomide? Thalidomide was a drug that was developed as a sleeping aid for pregnant women back in the 60s, and it caused horrific birth defects, right? Like kids were born without arms and legs and that kind of stuff. Luckily, it was never approved in the United States. But there were some babies born here because their mom or dad went to Europe and got it. Well, it turns out it works by, it decreases neovascularization, and it also does something to the immune system that is not well understood. So thalidomide was originally used, and then another drug came along, lenalidomide, and then there's a couple others out there. The problem is these drugs are being developed so fast that we don't have time to do complete clinical trials to compare how to sequence them, how to combine them, and so we're kind of flying by the seat of our pants sometimes. The monoclonal antibody just came out, and it may have come out. Well, 4 new medicines came out for multiple myeloma in November of 2015. That's how fast things are changing. And they're not just Me Too drugs, they're stuff that's different. So it's never a good time to have myeloma, but it's better to have it now than it was a few years ago. And as hard as it is to believe, that's it. So, are there any questions? Are you totally confused about all this? I think that you fill out evaluations, and since this is the first time I've attempted to do this, I really would like some feedback on so whether we're going too fast, trying to cover too much, do I need to cover something else more in depth, because I just don't really have any concept of what I'm supposed to be doing here. So, if you let me know, I'd appreciate it. Is there anything we need to talk about on this?
Do you
Well,
have,
thank you.
I have a
Yeah.
question. Do you have PAs working with you? Just curious.
Oh, sure. So we have, we are living in the era of PAs. They're going to take over the world And we're sort of the vanguard. Actually, we were one of the first systems to use PAs in our stem cell transplant program, which we've only had only one has become addicted to drugs, and the other one just used them a little too much. So for our stem cell transplant program, we have 2 FTEs, of which one FTE split between 2 women, so we have 2 part-timers. And then on the medical oncology side, we have 2 inpatient PAs, and then we have 3 outpatient PAs. And the way that I work at the Stevenson Cancer Center down at OU, and our clinics are sort of specialized. So I do hematology transplant, so I have a couple of PAs that do that, and then there may be a PA that only does breast cancer, or colon cancer, and so they get specialized that way. So, and there is a PA oncology group and journal. So I mean, it's yeah, we use a lot. And all my patients like my PAs better than me. Well, thank you all.
Thank you.